Okay, thanks very much. So the question that was posed for me was transcervical carotid artery stenting, will it change our practice? I do have a disclosure. I'm one of the principal investigators for the ROADSTER 2 trial. And the simple answer to that title question is yes, this will change your practice. In fact, it is a no-brainer, and I'm going to show you why. So for those of you that are involved in patients that have carotid artery disease, we still have some challenges in terms of treatment with these patients. The outcomes with carotid endarterectomy, especially in patients that are high surgical risk, are still not very satisfactory. If you look at this graph on your left, or symptomatic patients on your right, asymptomatic patients, and you can see patients, the slides are not on the screen.
It's great. Let me see what I can do.
We can all see it.
Thank you. Okay, let's start again. Because you've got to see my Homer Simpson slide. It is really a no-brainer. This is going to change your practice. Okay, I was wondering why nobody was laughing. Usually you get a little bit of a... This is a tough cardiology crowd.
It's the crowd.
Okay, as I was saying, the outcomes for carotid endarterectomy, especially in patients with high surgical risk, are still somewhat challenging. So in this graph, in the middle actually, symptomatic patients, and on your right, asymptomatic patients, you can see that the 30-day stroke and death rate is still remarkably high, 6.4% for high surgical risk patients that are symptomatic and 3.7% in asymptomatic patients, and this is much less in patients that are standard surgical risk. So what do you do with these patients that have high risk factors for undergoing carotid endarterectomy? Well, the usual answer has been transfemoral carotid artery stenting. And I am a surgeon, but the disclosure is that I do carotid endarterectomy, transfemoral, as well as transcarotid artery stenting, all modalities. And this is a patient, as you can see from the timestamp, many years ago that we were considering transfemoral stenting, and we were going to enroll in the CREST 2 trial, and the trial investigator said, forget about it. I mean, this is not an arch that we want to, in a patient that we want to enroll in the trial. So we did treat this patient, and if you look closely at this slide, you can see there's a surgical instrument at the bottom of the screen. The patient has a couple of tandem lesions, and this was treated pretty easily using TCAR. And TCAR is transcarotid artery revascularization. It's a relatively new way of accessing the carotid artery and treating the lesion in patients with high-grade disease. This cartoon that many of you may have seen involves a small incision in the neck where we access the common carotid artery. We place a 8 French sheath in that location, an 8 French sheath in the vein. There's an extracorporeal circuit that reverses blood flow. We put a clamp on the carotid artery below the arterial sheath that leads to obligatory reversal of flow in the carotid system when we're doing intervention. And this runway to do the procedure with a very short sheath and a short transcarotid system, only 57 centimeters, makes this actually a very straightforward, easy procedure. And as one of my colleagues has said, this converts a challenging carotid stenting procedure into an iliac angioplasty and stent. And that may not be a wrong analogy. These are the outcomes in ROADSTER 1, which was published a few years ago, 1.4% 30-day stroke outcomes, and when you compare that with the CREST patients that either went endarterectomy or transfemoral carotid artery stenting, it was fairly favorable. And that leads to the question, what is the safest way to treat a embologenic lesion in the carotid bifurcation? You're trying to prevent stroke, but the last thing you want to do is avoid causing a stroke during the intervention. And why don't filters perhaps work as advertised? Well, there are multiple steps before you even place the filter. You have to cross the lesion before placing the filter. You have to cross the arch. You have to get to navigate your sheath to that location. And clearly there can be filter-related issues, malapposition, undersizing, and recapture. Well, let me just spend a few minutes talking about the ROADSTER 2 trial. You heard about thousands of patients in medical trials, in intervention trials. There's just hundreds, and this was an FDA-mandated mandated post-approval study, a minimum of 600 patients. 70% of the sites were new that were not involved in ROADSTER 1. We had a neurological evaluation at baseline, after the procedure, and at 30 days. These are the traditional inclusion and exclusion criteria, anatomic or physiological high risk, and exclusion criteria that is typical for most carotid stenting studies. We had 632 patients in the per protocol analysis. This is the baseline data. A lot of octogenarians, a quarter of them symptomatic, 10% with contralateral carotid artery occlusion. The ROADSTER 1 operators, their procedure information is in the middle, ROADSTER 2 on the right. Despite having 70% new operators enrolling patients in ROADSTER 2, the operative variables were fairly similar. Skin-to-skin time of 75 minutes, reversal flow time of 11 minutes. That's the critical period of time when we're doing the intervention. 5 minutes of fluoro time, in contrast, usage of 36 cc's. Procedural success was extremely high. And these are the relevant outcomes in this 632 per protocol patients. Stroke death MI rate of 1.7%, stroke 4 patients, 0.6%, stroke and death 0.8%, and the one patient that died, unfortunately died of a ruptured aneurysm 2 weeks after the TCAR procedure. If we compare ROADSTER 1 to ROADSTER 2, fairly analogous results, again, despite a new cohort of investigators, many of them who were TCAR naive when they participated in this trial. If we look at patients that are symptomatic versus asymptomatic, I think all of us that do a lot of carotid intervention are mostly concerned about those symptomatic patients, but at the bottom you can see fairly, again, surprisingly good results in both ROADSTER 1 and 2 with symptomatic patients. Recently, we just published our multi-institutional analysis, 4 institutions, university hospitals, WashU, Indiana University, and Austin, Texas. We had over 600 revascularization patients, and we propensity matched 292 TCAR patients to 292 carotid endarterectomy patients. And you can see that the results, 30-day stroke was 1% versus 0.3%, death was 0.3 versus 0.7, and 1-year stroke was 2.8 versus 2.2. All of these were non-significant differences. The only difference was that TCAR had a much lower incidence of cranial nerve injury, 0.3 versus 3.8%. So, ladies and gentlemen, in conclusion, I think transcarotid artery revascularization is safe and effective. It's something that's evolving. We're getting more data on this. Clearly, a comparative trial is needed, but outcomes with TCAR are consistent across physicians with varying levels of experience, which probably is related to the resilience of this procedure. Thank you very much.